Bring it to the screen. All right. Good afternoon, everybody, and thank you for joining us another week of Journal Club. Dr. Merlin's on his way in. We're going to go ahead and get started right off the bat, and we'll start with some interesting cases for the week. Who'd like to start?
So yes, I'll start. Brian with ED residents from north of Israel. So in the ED, we saw actually a patient earlier this year. This was a 42-year-old female, walked in by herself to the ED. Basically, she has a history of hyperlipidemia. She's coming in with some chest pain that actually started 9 hours prior to arrival. She said the chest pain was basically substernal, midline, basically radiating to both her armpits and her back. She was also complaining of some shortness of breath. Initially, when she came in, her vitals were completely stable, and on exam, nothing really significant. As far as her past medical history, she has hyperlipidemia. She's not on any medications, no hypertension, no diabetes, or anything like that. And of course, she was a smoker, like many of our patients, smoked for the last 20 years. So for first EKG, it came back, and there are ST elevations pretty much everywhere in lead 1 and 2, 3 AVF, B2 through B6, and everyone's thinking this is probably pericarditis, right? With all these diffuse ST elevations, what else could it be? And you know, the ST elevations were concave, so not necessarily convex is what you consider as far as STEMI. There weren't any PR depressions, but there weren't any STL depressions as well, which would be more indicative of, let's say, MI. So the team's thinking pericarditis, gets worked up, and the first trope comes back at 2. Now this is very interesting. Seeing that, you know, with most cases of pericarditis, you might have elevated trope, but it shouldn't be that high. So this patient ends up getting admitted for the pericarditis, needs trending of EKGs as well as the troponin, and the next troponin after 4 hours later comes back at 20. So this is definitely not pericarditis, right? This is maybe perimyocarditis, which is actually very uncommon. And in order to diagnose perimyocarditis, you would need a full cardiac workup, including a rule out of ACS, which means like angiography to make sure there's no thrombotic stenotic lesions. Throughout this case, the EKGs were largely unchanged with ST elevations in 1, 3, 2 AVF, and as well as the anterior leads and lateral leads from V3 to V6, largely unchanged throughout the course until she gets to echo. When she gets to echo in the morning, they find some abnormalities, and there's some apical anterior septal like wall motion abnormalities, which wasn't expected. So this lady ends up going for a cath, and they find a mid-LAD obstruction, and she gets a stent, which is actually very interesting, considering everyone thought it was going to be pericarditis versus perimyocarditis from the get-go. As far as pre-hospital care goes, you might get diffuse ST elevations on an EKG. It might be a very young individual. Maybe she has upper URI symptoms prior. You don't always know, if this is a STEMI or not. And if you go on the hunch that this is most likely pericarditis, you might actually be missing a STEMI. And with that being said, it would be unwise to at least, activate the cath lab, get a cardiologist on board, basically cover yourself to make sure that this isn't something more serious than just pericarditis.
Yeah, this is something we call-ins on the console all the time. Medics are asking, here's a CKG. It's kind of, I don't know, it's a little bit of this, a little bit of that. What should we do? Should we call it a STEMI? And my answer is almost universally yes. Mostly because calling it a STEMI mobilizes resources, depending on time of day. They may not even have the nurses in the hospital that need to set up the room. The doctor may not be in the hospital. He's got to come in. They can be 30, 40 minutes away. And STEMIs are time sensitive. The earlier you get them, the better our outcomes, the less morbidity especially, but even mortality. But morbidity, because the longer you leave this dead heart there, the more likely they are to have this heart failure. And that's like lifelong problems. You're a young guy, you have a heart attack, and now you have such bad CHF you can't walk upstairs. That's very, very life inhibiting, even if you survive it and get stents and whatever. So really we want to prevent these bad outcomes from happening. And so the best thing to do is really to kind of activate these resources. Now it's definitely a balancing act really between if we overactivate and we're wasting tons of resources, and at a certain point cardiologists are going to be gun shy. But at the same time, at the end of the day, they are going to be the one that decides whether they're going to take this person to the cath lab. So getting their early input, often what we'll do in the ER is we'll send them the EKG. Hey, what do you think? This is could go either way. Here's the story. The story sounds really good. EKG is kind of not so specific. It just sounds like this one should go, and it's a lot of back and forth. But activating those resources early can really help the overall patient. And if they cancel it, okay, they cancel it, no big deal. Don't forget, these people are getting paid to be on call, and we don't want to get there and all of a sudden then have to do it, get behind the 8 ball. And as we heard from last week, a lot of these patients, right, they sit with their MI for too long, they start getting very irritable membrane, they're going to have episodes of VTAC and VFib. So we got to get them early.
Yeah, I mean, a lot of times, like, a couple points from this is one, we talk about the NSTEMI patient that we feel that, should get urgent PCI within 72 hours, which is pretty, well studied. Some of these patients, we talk about cardiac arrest that need to be, should benefit from even within 24 hours. But the STEMI, there's no doubt about it that, they should get immediate, PCI intervention. So the question is, how do we catch these and how do we avoid missing some of these STEMIs? I think this is a great case because a lot of times, we tend to hedge. And there's 2 points I want to make. We talked about this last week too a little bit about one, if you're in doubt and there's a concern that this EKG is borderline at best, but the patient has a good story, doing serial EKGs sometimes can be beneficial. So that's always been proven to be my kind of main mantra as far as trying to get those done. So, and we talked about this last week, how often do we do this? We know that's the board answer, but we don't do this very often. And it's something that we typically tend to avoid to do. I'm not sure for what reason, but, when in doubt, I think it's okay to kind of look at the morphology and see if it's changing, especially if the patient's presenting with persistent pain. I think the second point, especially in today's world in emergency medicine, I think it behooves us to if you have someone that you're concerned about a STEMI and you're seeing some elevations, and you're concerned that could this be possibly, a STEMI, do a bedside echo. Okay, so I mean, the number one, you're going to look for any of that effusion prostate going on that you think is pericarditis, but then also you're looking for that wall motion abnormality, and I think that's huge. Trying to look at, whether or not there's an inferior wall defect or a lateral wall or septum down, looking at your entire wall motion and saying, okay, this is now consistent with, my STEMI. That kind of, gives me further evidence and further ammo to be able to pull the trigger of calling it, calling a STEMI on a patient. So I think, doing a bedside echo early, looking for wall motion abnormality. If we've got good contractility, concentric wall motion, and we're thinking, okay, this is probably pericarditis, but if your exam and your echo actually shows something different, I think we should definitely lean towards that. The other point I think that's probably relevant is that what you made, Drew, is that a lot of times we tend to worry about our consulting services, and during the daytime it's really easy to call a cardiologist who's in-house, probably in the cath lab doing an elective patient already. But during the off hours when they're not there, we tend to hedge, and I think a lot of that hesitation shouldn't be there. And I mean personally, I'm in one of my shops where I don't have ultrasound 24/7, And so a lot of times, you have patients that you're thinking about ruling on ectopic, and a lot of times they say, well, do you really want to call an ectac? And I'm like, absolutely. I'm not waiting 4 hours to diagnose an ectopic pregnancy. So, unfortunately, we need to call somebody in. And I think, you're understanding that, there is a respect of our colleagues, and knowing that, we respect their time, but at the same time, we have to, be advocates for our patients. And if we feel like they deserve a stat consultation or stat testing of any kind, I think we should push for it.
Yep, absolutely.
Any other cases?
We're kind of light this week
Yeah.
because Josh is out on a critical incident. Mike is up on a standby in the Poconos, and Alex is actually on the flight somewhere over the ocean, flying back toward us from a patient transport for critical transport. I don't have anything offhand. Haven't been in the ER this week, and I think everyone's out enjoying the summer, so most of the emails, all calls were run of the mill, what we kind of see all the time.
Yeah, I mean, a lot of times what we see in the summertime, especially with our pediatric population, unfortunately, is a lot of drownings. It's not only just ocean that we see. A lot of pool drownings. Certainly, tub drownings are throughout the year, but certainly we see a lot more pool drownings during this time, and it's always very prudent that we stay very kind of cautious and aware. And with these patients especially, where we talk about mantra of cardiac arrest or drownings, and if we have a patient in cardiac arrest who's status post drowning, the question is, how do we treat these patients? And my mantra has always been establish the airway quickly, because you want to be able to, basically give them what they really need. This was a respiratory kind of arrest, essentially from drowning, that caused them to go into cardiac arrest, and we have to kind of reverse that process. So it's always beneficial for that. We had a discussion last year, which is interesting, about some near drownings where you have patients who are like hypoxic, who probably might have just a little fluid in their lungs, and their VQ, they have a bit of a VQ mismatch, and some of these patients actually receive CPAP in the field, and that actually did them really well. I don't know how much studies they're doing on this, but we see this time and time again. But this is a season where we start seeing a lot of this, and we got to be on top of our game, and especially with pediatric airways.
Yep, for sure.
All right, I think we'll move into the articles now.
I can start with one.
All right, which one do you want to do?
I can start with the traumatic pneumothorax. Basically, this is an article from the Journal of Trauma and Acute Care Surgery, looking at after trauma patients receive a chest tube, when can they then get on an airplane and fly? The reason this is a question, because some of the federal guidelines, and certainly the airline guidelines, like when you call Delta and you say, had a medical procedure, have a note from my doctor that it clears me to fly, can I safely fly after having a chest tube and having it then removed? When can I go? Most of their answers are between 14 and 21 days. The answers you get from the cardiothoracic surgeons can sometimes vary, but a lot of people just kind of go back to that 14, 21 days. And the question is, where did it come from? Expert opinion, aka guessing, right? We don't have a good data set for that. So that's what this paper was really trying to look at and find out. And the reason they wanted to know is because, interestingly enough, the military guidelines are after a patient has a chest tube and the chest tube is removed, they are able to fly in the military after 24 hours. So why the big discrepancy? What's the difference? So this was a group of people led by Dr. I guess it's Zonis. I don't know if that's the correct pronunciation of his last name. He's out of Portland, Oregon, and they did a retrospective study on basically a military cohort. They looked at 73 different patients who met criteria basically of not being too severe and having a chest tube and then having the tube removed, and then they as long as they had the tube removed 24 hours before flight, they were included in the study, and then they kind of went all the way through the gamut. The median period of between tube removal and flight was 2.5 days, but it ranged from the interquartile range was from 1.5 to 4 days. So a lot of them were much earlier than what we would actually expect. And then they basically followed them up. So most of these patients were coming from the Germany hospital. Oh no, I can't even say the name. That's the one. Yeah, links. Basically the main U.S. College of Surgeons accredited military hospital based in Germany. So a lot of these patients, and they take surgical patients from all areas of conflict, from most of the countries, European, African, Asian. All of those militaries can all kind of refer through to this military hospital. These patients had a varying range of actual penetrating trauma. They all got chest tubes. They were at this hospital, and then they were flown from the Germany hospital to another destination hospital, which then recorded follow-up. So they were all participating. And then I believe they followed them for 30 days, just looking for any recurrence or incidents. And none of the patients that flew had any recurrence at 30 days. And then they looked at kind of what was the ideal. Let me pull up their actual stuff. Interestingly, this was between 2008 and 2012, so kind of times of still high military conflict. I should mention as a side note on the kind of as a preface, why do we care about this, right? So when patients are at ground level and then they're taken up in the air, most of the military transports and even civilian aircraft, the air is pressurized, but it's not pressurized at sea level. So it's not pressurized at basically 0 feet of elevation. Most of the aircraft are pressurized. Military between 5,000 and 8,000, most commercial around the same range, although I think they tend to go up a little bit higher. And the reason is a couple: cost and how much pressurization you want to be comfortable, but at the same time you don't want to over pressurize and have too big of a difference between inside and outside. And why this matters in pneumothorax is because even when we have a pneumothorax, we put a chest tube in, we've removed or shrunk the pneumothorax, the lung is re-expanded. It's not 100% re-expanded. And in the process of removing that tube, you likely are going to get some residual air, which normally will passively diffuse into the lung until it can kind of close the space altogether. But that's at sea level. So now if you take that same person with this maybe 5% or 10% pneumothorax and you take them into the air, they don't have that same weight of the atmosphere pushing on that balloon in their lung. So when you take away some of that weight of the atmosphere, now the air that was 5% can easily expand because it doesn't have so much weight pushing it down, compressing it, and so you can make a small pneumothorax into a bigger pneumothorax. And the concern is you make a small pneumothorax into a big pneumothorax, compromising oxygenation, or even worse, you take it all the way to the other end where you get to a tension pneumothorax, and now you have patients that are at risk for cardiac arrest in the air, where you have limited resources and limited room and limited interventions. They did, but looking at these patients and through the study, most of them were transported relatively early. Only a few of them, I'll have to pull up the actual results on the page. 40% of the patients had at least one chest tube removed. And then, let me pull up the last, where's the actual, so the risk, in the 1980s, when they did this expert consensus, this Commission on EMS Services, they were trying to answer this question for airlines. That's where we came up with the expert consensus of 14 days, because they, at the time, thought there was a risk of gas expansion somewhere in the 20 to 30% range. Then they kind of, a couple of the Aerospace Medical Association and some of the other groups looked at that, said it's probably not that. The military looked at this kind of the same data and said, well, yes, maybe that's true. However, there's a lot of risk of leaving someone in theater versus getting them to definitive surgical care. We're willing to take some of that risk, and that's why they took their window all the way down. But then they noticed, and that's probably where the study had come from, that they weren't really experiencing high rates of recurrence. They didn't actually mention the rates of recurrence from the people in those early studies, but basically, even though only a couple of them had required some intervention like oxygen, basically none had serious reoccurrence of clinically significant. I would say like tension pneumothorax in the air. So some of them did have some pneumothoraxes recur, but most of them actually did really well. I'm just trying to find the numbers, which I somehow lost on my paper here. 65 patients in another study out of the 179 who were transported had to have subsequent chest tubes. But again, these were all early military studies. So this study, after looking at basically all the data and looking at their retrospective analysis, they found that our new recommendation should really be 24 to 72 hours of close in-air observation is a reasonable time frame, right? We probably shouldn't be putting these people on a commercial airline where no one can watch them with limited intervention, but certainly in any kind of air medical transport, much more our world, and certainly military air transport, 24 to 72 hours was they all did fine. They all did good. And then at 30 days, none of them had any clinically significant recurrence. So probably 14 to 21 days was a little bit overly conservative. Maybe if you have a patient that's coming in with a chest tube, 72 hours is probably a reasonable number. It might need to be a little bit further, especially if you're going on a commercial airline, but if we're able to transport them through EMS transport, air medical transport, military transport, early transport was demonstrated in this retrospective review to be equivalent. No adverse outcomes. I don't know if anyone else had any other comments on this.
They talk about, once they removed it, but they didn't say like how long the chest tube was in for.
Right, they did not say that stuff.
So these are mostly trauma patients, so it makes sense that there's probably a hemopneumo or some other component there. But were these straight pneumothoraces versus, a hemopneumo, and did they have any complications or any rib fractures? And so was there any lung contusions or lung lacerations for that matter? So, there's a cohort of information that we have to rely on. Because that has a lot to do with, the pulmonary physiology as well. Once you start into the air and the atmospheric pressures increase and stuff, what are some of the other ramifications of having a lung laceration, right? Versus not, and how fresh is that versus someone having maybe a contusion or not having any type of lung trauma whatsoever. So, there's a lot of variables, I think, that are out there. I think straightforward, thinking about, development of reoccurrence of pneumothorax, certainly that's there. Certainly waiting, I think, a couple of days is perfectly fine. But at the end of the day, I think I like the fact that it said, okay, once the chest tube is out, now how long do we wait? Because we know that we've had these patients who have no leak, who are now off a suction, have been monitored, have good volume, and now, okay, we're going to put these people off. And I think those patients are probably going to be pretty stable at that point. And then once you've removed the chest tube, I think it's perfectly reasonable to wait, anywhere from 24 to 72 hours. I think that's perfectly fine.
Right. Yeah, I think that's an important distinction. These were patients that were managed by the trauma surgeons and cardiothoracic surgeons, and they felt like their lung lesion or the initial cause of injury had healed.
Right.
That's why then they were able to change from having the chest tube on suction to room air, and then to pulling the tube. I would say most people get a repeat chest X-ray some period of time after that chest tube. But they felt like they were, their lung had healed, the process was over, and the small residual air would not be a significant problem. I think the study was kind of going to show that is indeed the case. And probably the thing that incited this is, we have lots of military transports, and I bet just their anecdotal clinical experience was that we hardly ever have this problem.
Right.
Probably what spurred it, especially compared to the other guidelines.
AJ, any comments?
My comments would just be explaining why they did what they did. So if you scroll around all the way to the bottom, page 19, you'll see the table. And I've been asked so often, why are we reporting median values over mean values? And so why are we reporting median with our age value variable? And this is because we're gonna have bulking of our data set on age, because interquartile range is 75% minus 25%. So you have 50% of your variables lie in your interquartile range. So 22 to 26, we're having bulking. So that's why we're reporting age as a interquartile range and not a mean. And they do the same other thing for injury severity of score and AIS chest. So
right.
Chi-square frequency. Yeah, nothing really kind of strange, or unless you guys have questions.
And so basically, they're picking interquartile just to kind of take out the extreme outliers.
Exactly. Yeah, because that's exactly what you're doing with an interquartile range. Because if they didn't, it would give you an unreliable skew of what you're looking at. Because you might have like one person who's 90 years old and pulling up all of your average age, and it just doesn't make any sense anymore. So that's what interquartile range is. It eliminates outliers.
Okay. And most of these are going to be young patients anyway, from this study at least. They'll probably fit in a pretty narrow kind of window to begin with.
But even if we increase our sample size to around 1,000, I would assume you could probably end up taking away interquartile range. It'll start approximating to a normal distribution. You can start reporting the mean.
Okay.
So it can change just depending on your sample size and what your data set looks like in the scatter plot.
So when you have smaller sample sizes, usually you're going to have this kind of happen typically?
Yeah, all the time.
Okay.
And is that why they're reporting it here, just to show that they weren't skewing their data? Like, why are they just mentioning it to kind of for everyone's information, or is there a statistical?
Well, median
validation?
is usually median difference is what you'll see in most data sets and studies. Because there's really no other way to report it with their data set. Like,
but I guess is the reason they're reporting it just for informational purposes, or is it to show that this was reliable data because look, everything's kind of.
I guess both, because you can say your data is reliable once you take an interquartile range and you see where everyone is sitting. Right. So we reliably know what this age range is going to do.
Yeah. I think more so not for the age, but maybe for the injury severity score. That would probably, you have that outlier who's got a very high injury severity score, and you want to take that out because that's probably a multi-system trauma, and that patient probably doesn't fit in the bulk of like the traumas that they're seeing.
Angios done. They were known to have CAD, and they were basically trying to figure out whether let's say occlusions that were that had changes or abnormal flow should be stented versus let's say like a 50 or 60% stenotic lesion. So basically they found that if you stented lesions that had a decreased flow or a decreased fractional flow reserve by less than 0.8, if you stented those lesions, patients had generally better outcomes than the patients that you just stented arbitrarily based on how the vessel actually appeared. So for them, their study found that about 13%, the 1 year event rate was 13% versus 18% in patients using the fractional reserve flow reserve. And so the 1 year primary outcome was either going to be death or maybe an MI or a repeat revascularization within 1 year. So going on to this trial, the 5-year outcomes, PCI guided fractional flow reserve, kind of builds upon that. In the same way, it was a multi-center randomized trial looking at about 1,200 patients in both the US and Europe. In this case, there were actually, so people with stable CAD, everyone was getting an angiography, seeing what kind of lesions they had, and everyone had their lesions basically characterized by this by the fractional flow reserve, right? So if the fractional flow reserve was less than 0.8, that was clinically significant, most likely stenotic, requiring either medical treatment or a stent. So in this case, half of the patients got a stent, the other half did not receive the stent and were basically managed medically. So what they found was similar to the FAME2 trial. They were looking at 5-year outcomes, also looking for primary outcome of either urgent revascularization, which is like a patient came in within 5 years, had some abnormal EKG changes, maybe some ischemia, had to get revascularized earlier than warranted, versus or if someone came in with an MI or there's a change in death. Those are the primary outcomes, and what they found was there was actually a difference, 14% versus about 27% between the two groups, and most of this difference was actually due to the increased urgent revascularization in patients that were given medical therapy and not the stenting based on the flow. And what they also found was more patients had relief after the stenting was placed for those that had the stent placed. So overall, I mean, it's not one of those studies that necessarily applicable to EMS group, but it's a different way to look at yes, what is when the cardiologist should actually stent the patient. Should I do it based on purely what the angiography, the percent of stenosis versus what is actually clinically significant in these vessels? Is there obstruction of flow? And that's what kind of the study is going off of. That's pretty much it.
I know this is kind of a topic that's outside of our normal EMS realm, I think, but it's a huge topic in cardiology, right? Because just a practical level in their world, they can do a cath, or maybe you do a CT angiogram and you look with a CAT scan, and you can see a vessel, or you have the vessel, and let's say 50% of the vessel is blocked. Does that need intervention? Does that not need intervention? That's the difficult question they have to try to answer. One good tool they came up with is the fractional flow reserve, because we can say, no, it's 50% blocked, but look, they get plenty of flow through there for that actual muscle tissue. So it's fine. We don't need intervention. And caths are not without risk, right? Caths can actually have some serious risks. So that's why it's a big, big topic in cardiology right now. In fact, in a second we'll talk about one more step, but I want to make sure there's no other questions or statistical input for this paper.
I'll probably just talk about just the intervention itself and the efficacy of it and how it applies, because you have 13.9% of your people in the treatment group are having a primary composite endpoint, and you have 27% in the medical therapy group or control group, if you want to put it that way. So you're seeing a very profound protective effect, the hazard ratio of 0.46. And but what I would like to look at is what is in the composite endpoint, and you have death from any cause. And if you look from death from any cause as part of the composite endpoint, you'll see that it's non-significant in our composite endpoint. And so my question is why they put it there. Why would you put death from any cause as influencing our composite endpoint if we're only caring about myocardial and urgent revascularization? Because we would have seen more effect without it.
I think that's always a case that we look for whenever we're looking at any type of these types of, we look at end mortality. And so in most any cases that we're looking at how does it affect one, the significant lowering of like the primary endpoint, but also like the endpoint of death is something that we always kind of look at. Is there a mortality effect to whatever intervention that we're doing? So I think, looking at, MI and revascularization at 5 years is one thing, but then looking at any type of death is another, yeah.
Yeah, I mean, I was almost thinking, why didn't they just split it up and look at the primary endpoint at two different levels of stratification? Because you would have seen way more effect with our hazard ratio. It would be closer to 0.345 or something. So that's kind of a comment of mine. How clinically significant that is, I'm not exactly sure. That's up to you guys. Unless you guys have questions on why hazard ratio or relative risk, or what are they censoring, and so on and so forth.
If you want to comment on hazard ratio.
Yeah, that's going to be my question. Yeah. Remind me again, hazard ratio.
Okay, so hazard ratios is when you're censoring something. So you're going to be following a bunch of people over a point of time, and you'll notice that they're not all going to be in the study for the same amount of time, because they're going to have different exposure start points and different exposure endpoints, and they're going to die at different times. So you're not having a start and end point. Like when you're doing a regular clinical trial, you're going to have, they got treatment, and then it ended 6 months later. Time is not, we don't care much about time in the true time varying aspect. We're not censoring anything. So cognitive proportional hazard ratios, they allow for us to censor time to provide a more accurate cumulative estimate of our hazard ratio. And that's why you'll see most of the studies, especially with death, are kind of occurring with hazard ratios, because they allow for that estimate to be more proximate in regard to time. The calculation of it is a little bit more complex.
And this is starting from not the intervention itself, but looking at from a period of time.
Yeah.
Not so much when the actual intervention happened. So it could be during a 5-year period that you're keeping all the because I mean, the study itself is
On,
randomized.
on the average, yes. If they didn't study exactly, I'm not 100% sure.
Okay.
Let's see. This is pretty statistics heavy, this study is. So I feel like I could probably just ramble on for like an hour about it. Have you guys gone over landmark analysis before?
No.
And the whole idea behind it? Because, so in landmark analysis, you usually have most of your deaths usually occur right after surgery. So you do open heart surgery on somebody, most of them are going to die within the first month. I don't know the exact average, but they're usually going to die within the first month. So you start grouping them by time, and this is, so you put a landmark of like, let's say 1 month, what's a relative risk or hazard ratio 1 month after surgery, and that's usually the benefit of landmark analysis, is because we already know at the beginning, like we already know that landmark is they're going to have this risk, so we're going to start at a different time point, and that's basically the gist of a landmark analysis.
Okay. All right. Any other questions? All right.
Not for me.
Other
So then
articles
I
you wanna
guess I can
cover?
go on to basically a continuation of this topic, which is now maybe rather than the invasive cath lab fractional flow measurements, this group here looked at using CT, a CT angiography. This is from the European Heart Journal, and they are looking at several papers, almost like a literature review of this topic of fractional flow reserve, and kind of, will this help us? Can this be an alternative to doing actual catheter-directed fractional flow reserve? So basically what they did is they looked at kind of the literature. They give a brief overview kind of what Brian just mentioned, of why fractional flow helps us. It helps us figure out which patients need what, and therefore we don't add risk to the patients who actually were doing fine. Even though they had a 50% lesion, they were getting plenty of flow. We don't need to expose them to the actual risk of the procedure itself. And then even without the stents, just the risk of the measurement is risky. So is there a better way? And they propose here that basically, yes, the CT angiogram can give us the same kind of information. Without going too deep into the paper, they basically looked at the same numbers. They're able to derive by using CT angiogram and live analysis of blood flow through these lesions. So not only what we've been able to do up to this point is look at the percentage of how much lesion, how much of the vessel is occluded. 80% occlusion, likely to have, in fact, maybe this person then needs to go on to get a cath in the stent. They were able to look at that live CT and during the angiogram, look at flow rates and determine fractional flow based on these newer generation high resolution CT scanners. And then through the studies, they looked at kind of the other papers on this topic. As many of them are kind of looking at CT fractional flow versus invasive fractional flow. Are they comparable? Are they both valid? And the answer there is pretty much yes. Certainly, by having an invasive catheter, you can get much more sensitive measurements. And the downside of CAT scan is when you do a CAT scan, you're doing a CAT scan of the chest. However, this is a reading over time, which means the person's alive, which means the heart is actually beating, and the person is trying to take a breath. Even though we try to limit both of those by timing the study, there's still some movement. Also, depending on the angle and the way the person is situated, you might get some refraction of the X-ray waves. They might go through the bone, which can kind of adjust the measurements themselves, or they might have other implanted devices, like a pacemaker, or they might be sick enough to need actual leads that may interfere. A couple of the studies were looking at cost analysis. Certainly, if you have to pay a cath lab with a whole group of staff and then the doctor doing the procedure and buy the equipment, the invasive procedure is going to cost a lot more. But the CAT scan machine also has an initial cost. However, we can use that machine once after the initial cost multiple times. So in most cases, these papers were looking at the cost analysis, and the CT was much more cost beneficial. And then a couple of them were looking at kind of outcomes in that, and is this a useful technology? So this paper is kind of grouping all that together. they pooled the papers and the information, and basically they were finding that the CAT scan fractional flow reserve analysis was saving around 200 pounds per patient. That's like European pounds, not weight pounds. And then they also said there was a much lower there was a reduction in the relative adverse events of 4%, which is not insignificant because the adverse events during CAT are like serious adverse events: dissections, aortic punctures, pneumothorax, and so they concluded this is definitely an area that we need much more research, right? If we can get all this information, we can save the healthcare system a lot of money, because people who may have lesions that previously in years past we would have stented, we now know they don't need a stent because we can see for sure whether or not they're getting the adequate blood flow. So then we don't have to just guess whether what lesion needs intervention. 100% probably needs intervention, but what number below that needs intervention? It's been a real gray area, and now we can definitively measure it on CT angiogram and find out, saving the system money, saving the patient risk. This is probably where cardiology is going, and this is why this is such a huge topic in medicine. If we can bring you in and give you a quick CAT scan and tell you, here's your printout of your heart risk, and if you need a stent, go in the stent line. If not, you go in the home line, and bam, you're done. We're one step closer to the Star Trek tricorder being able to diagnose every disease in 1 second.
This is true.
Yeah.
I mean, a lot of this is like you mentioned, Drew, was like complication. I mean, complication is key. And there's little I mean, there's they stent, they do CATs on people all day long, but there still is that risk that you run in. And I mean, the relative risk of someone in a CAT scan is going to be radiation exposure versus excuse me, versus some type of contrast dialogy that you might have. I mean, but that's about it. Sometimes your IV might infiltrate. All right, that's fine. I mean, but that's relative to the actual risk that you run. One of the things that you have is, one thing you mentioned, the image, the slice, and how they're sitting or versus, breathing and whatnot. You also have to have the patient become bradycardic. So a lot of times, most of these patients, we want them to have a heart rate around 60. So we'll give them something to augment them and bring their heart rate even lower, so we can get a good perfusion during your diastolic phase, and you get good coronary filling. I mean, I think this is a good study. I mean, it's good. It tells us that this is kind of what we're looking for. I mean, typically there's a lot of institutions that don't have, unfortunately, CTA capabilities for coronaries. I mean, it requires a cardiologist who's trained into interpreting these, and then also having radiology on board to do like the rest of the bone lung kind of structure analysis and readings. So that's easy to do from a radiology perspective, but from CARD's perspective, there's very few facilities that really do this. But I will tell you that this is probably more so an up and coming trend. You want to see this in the patients who are like younger. I personally, in my shop, we do have CT coronaries available, and I mean, I will typically utilize them on patients who are, I believe, higher risk but are younger in age. And those are the subset of population we're looking for, that soft plaque, and that's going to be more detrimental to them. Getting a calcium score from your CT coronary is going to be huge. So I mean, being able to look at the coronary perfusion, looking at your actual vasculature and your vessels, and then getting a calcium score on these younger patients who are high risk, especially nowadays. I mean, this is kind of where it's going to be at, and this is going to be completely non-invasive. So I think this is where cardiology is going to be going towards in the next decade or so, and you'll see more and more of this kind of popping up, and you'll see facilities actually doing this, even maybe at one point as a screening tool for CAD.
And it adds a lot of non-invasiveness, and that it's kind of where we really have grown. Right? You can imagine in the 1950s and 60s, you got in a bad car wreck and you maybe were tachycardic and you had a tender belly. They had to cut you open midline to look and see if there's blood in there and look and see if there's any injuries. Oh, no injuries, all right, good. But that came with risk, right? So major surgical procedures that have risk, and if you didn't need it, you didn't need it. So when we were able to add in first like BPLs, where we could stick a needle in and see if there's any blood in the belly. Oh, there is blood in the belly, we probably should go look. And then we're able to advance to a CAT scan. Now we can look live and see, oh yeah, there's not only a little injury here, it's a grade 2 injury. We can probably just watch them for a little while and make sure the bleeding doesn't continue.
Yeah.
I remember talking to one of the old trauma surgeons when I first started doing trauma, and he's like, yeah, CAT scan has advanced so much, it's totally changed my career. He had started as a trauma surgeon, and was, by the time I was working with him, was in his year of retirement. And he's like, when we first started, right, we were invasive everything. And then somewhere along the way, we got CAT scans, which were great because then you could do a CAT scan of the head. It took about 30 minutes, sometimes up to an hour to get the CAT scan of the head. But that meant, in the patient who was obtunded or intubated, we didn't have to drill a hole in their head to see if they had blood and see if we needed to intervene. And now we're to the point where we can do a CAT scan of the head in literally seconds. And really, CAT scan of the entire body in seconds. Has the downside of radiation, but as we go through newer generation scanners, and we use the computer algorithms to have radiation when we need it and turn it off when we don't, we can still get the similar pictures. I think that's what makes everyone so excited about this development of this technology. Now we need larger studies to see if this is what we should be doing. Should we get rid of CATs altogether? But I think as a whole, we're definitely moving toward non-invasive imaging across each specialty.
Right. And I think this is kind of where the future is going to be. Being able to kind of analyze this and kind of go from there. But you're right, we're not cutting open people in surgery, we're sending them to IR even. I mean, so the same way, there's going to be more innovations in cardiology, and this is kind of one of the trends that we're going to follow, I think. Fractional flow is going to be something you're going to hear more and more about. And CTA coronaries are going to be something you hear more and more about. Doing screening in patients who are this kind of moderate gray zone risk area, not the high risk. I think high risk are still going to probably end up getting capped.
I would say in any given shift, I probably use the ultrasound more than I use my stethoscope. And
Sure.
That is the same idea, right? We can actually see and look. That really helps us diagnostically, rather than, well, we have something, maybe we need to investigate.
Adrian, anything on this one?
Criticisms, no. I don't really have any criticisms. I think it's a good paper. It's definitely showing the effect that they were investigating.
Mhm.
Unless you guys have any questions about the methodology, because there's so much within this that I could spend a year on it. Not even joking. There's a lot of methodology in this, and the reason why they're doing that is pretty long and drawn out. So,
What do you think makes it a solid paper? Just the methodology that they use, you believe?
say it again.
You're saying that it's a really well together paper in your eyes, statistically.
In my eyes, yes,
Yeah.
it's a good paper. Yeah, definitely. But I'm very for, especially when you're measuring time varying exposures and variables are kind of like the new method of finding causation for anything, especially in statistics, because just doing a start point and end point, there's a lot of interaction with time. Time, it can distort all relationships, especially with 5 years of follow-up, and there's just so much more room for improvement, especially in the methodology of collection and how you're analyzing the different set points at which you're analyzing. So, yeah, there's quite a lot of measurement error. There's a lot of biases, especially within time measuring exposures. But if you do a prospective study and you're measuring a time varying exposure and you have good collection of data, your ability to prove causation is way more dramatic than just some random ANOVA table, basically. So there's it's a pretty big deal in stats.
Yeah.
Yeah.
I mean, I like their kind of methodology as far as like how they're choosing it. Like,
Yeah.
their pretest probability for CAD, I think, is reasonable. I mean, that's kind of the stuff you want to go through. You want to risk stratify, and based on your risk stratification, move forward in your type of testing that you want to do. And I think that's a reasonable way to kind of go about it. You want to have people who have high, just like when we talk about like doing dimers on patients for like PEs. If you have a high pretest probability of having a pulmonary embolism, go straight to the CAT scan. Don't do a dimer, right? But if you have a low pretest probability, then do the other tests. So I think the same way, if you're having a high pretest, it's inappropriate to do a CT, right? But go straight to the cath. I think this is a good study. I like it.
Yeah, definitely.
Yeah.
I don't really have anything more to say about it.
Okay, sounds good.
Yeah.
I mean, I think this is it for this week. Next week we have I think the holiday, 4th of July, and after that we'll have July 11th is when we'll be back for another round of Journal Club. This actually is the last Journal Club for the calendar year for our fellows. Although we only have one fellow here currently, Drew. You know, it's been a great year. Thank you so much.